Welcome to the neurology block. We're looking at the anti-epileptic or anti-seizure medications and pharmacotherapy. In this block, we'll focus primarily on the anti-epileptic or anticonvulsant medicines, which are indicated primarily, we think of, for seizure types, but also because of their effect on nerve conduction, are sometimes used either in mental health, or some of these agents also used for neuropathic or nerve-generated nerve type pain. In 2017, there was a major reclassification in how we classified or described seizures. This was done by the International League Against Epilepsy, and the link to their website is here. We'll quickly go through some of those that new nomenclature and compare it a bit to the older nomenclature, as you may still see a lot of literature and clinicians speak in terms of the older type seizures rather than the newer nomenclature names for the very same seizure activity. The classification now includes primarily whether or not it is a focal or localized onset of seizure activity or a generalized onset of seizure activity, and then a third group where that's not really clear what the onset was. The focal onset generally has a very localized area in the brain where the onset of seizure occurs, and those are subdivided into whether or not the patient is actually aware of the seizure onset or whether there's impaired awareness by the patient of a seizure activity, and then further described as whether or not there are motor features or not motor features in the nature of that focal seizure activity. For generalized onset seizures, we define them as having a generalized onset and virtually always an impairment of awareness. Patient is not really aware of the seizure happening. And those may involve either motor activity or non-motor activity. The older term for non-motor activity were absence seizures. A more expanded description of that by the International League Against Epilepsy in 2017 described more of the motor features or non-motor features in both the focal onset and generalized onset type of seizure activity. The kinds of issues that are important when clinicians are thinking about classifying seizure activity include the onset and awareness of the seizure activity by the patient, and then a number of other factors that help further describe or categorize the seizure type. And categorizing the seizure type is important because the choice of our anti-epileptic agent is going to be really married to the type of seizure activity that it is to choose the best agent for the type of seizure that is presented. Some key features in seizure activity are listed in this chart of this table with the more medical terms to the right. And so as you look through the type of descriptors here, those will help clinicians really either if you as a clinician observe the seizure or more likely you're encouraging a patient and a witness to the seizure to help describe what the nature of the seizure activity is. These are really helpful in then categorizing the seizure and then picking the appropriate agent or agents. While this is long-term is typically done by the neurologist or the neurology team, you as a clinician may be faced with a new onset seizure activity in an emergent situation to initiate therapy, particularly for a serious generalized tonic-clonic type seizure, for example. One of the other things that we look at are the nature of whether or not the seizure onset was focal or generalized. Focal meaning that it started in a particular isolated area and then further spread, and you can see that on the left here, and on the right, generalized onset where it affected really both hemispheres typically of the brain, and there was an immediate loss of consciousness as well as a more full body type of presentation of the seizure activity. In this image and some of these charts that I'm using right around here are located all on the International League Against Epilepsy website that I referred to earlier. One of the last things to think about is some of the differences between the older terms and the newer ones. If you're a clinician or you've seen or worked in practice or familiar with epilepsy over the last few years, you're probably more familiar with some of the older terms like a simple partial or a complex partial seizure. Those old terms for simple and partial and complex partial and partial itself have been largely replaced by the term focal. And then whether simple being awareness and complex being impaired awareness. So you'll see some of the older terms still used by clinicians. You want to be just aware of that. So as we think of a patient who presents with seizure activity, as clinicians, we look at, well, how did that seizure happen? Particularly if it's a first seizure, but in any patient with seizure activity, we want to make sure that we are avoiding things that would lower their seizure threshold or increase their risk for seizures. So for someone who's predisposed to seizure activity, we'll find that metabolic abnormalities often contribute to seizures, electrolyte abnormalities in particular. We worry about hypoglycemia, for example. Even in somebody who doesn't have a seizure history, very severe hypoglycemia can present with seizure-like activity. We also see that true in very severe hyponatremia or hypocalcemia. Certainly, fever increases the risk for seizures, and even in children, very high fevers are known as febrile fevers, and these are treated by getting the temperature down primarily. And we'll see this in particularly toddlers and young children, not infrequently. A child who has, for example, febrile seizures related to a very high temperature, we get that temperature down, but that doesn't necessarily mean that that child then has to be on lifelong or long-term anti-epileptic medication. If the seizure was only caused by the very high fever, the issue is to manage the fever, prevent those high fevers again. We'll also see patients who have alcohol withdrawal, particularly having seizure activity. That can be often quite dramatic and important for us as clinicians to identify and to manage and address. And more about that when we, as clinicians in the curriculum, we talk about alcohol withdrawal and concerns for alcohol withdrawal and how to manage it. Insomnia can also lower seizure threshold. So patients who have a risk for seizures should try to have good sleep habits and to the extent possible, really manage their sleep-wake cycles to help improve their seizure control. Whenever someone has a new onset seizure, one of the things that goes through the clinicians' minds is whether or not there's a mass of some kind in the brain, a tumor, an abscess. And so that might be part of the workup. Most commonly, when we see a new onset seizure in a patient who comes in the emergency room who doesn't have a history of seizures before, or maybe who does have a history of seizures, we want to look at whether there was a toxin or a drug that lowered seizure threshold. And there are a lot of drugs or agents listed here. Let's go through some of the major themes with some of the agents that are here. We see some of the penicillins and antibiotics can do this, particularly the high-dose penicillins sometimes can cause seizure activity in predisposed patients. Theophylline and caffeine in high levels in sensitive patients could lead to seizure activity. In mental health, the older tricyclic antidepressants. Some of the other antidepressants can, particularly bupropion or Wellbutrin, is really notorious for lowering seizure threshold. The antipsychotic drugs, both the older typical and the newer, more atypical antipsychotic drugs, have the risk for lowering seizure threshold in a patient who has a predisposition to that. Lithium also can do that, both toxic lithium and sometimes even in the therapeutic range for very sensitive patients. Rarely, the very drugs we use to treat seizures can actually precipitate seizures, and that might be a change in the electrical conduction across the nerve fibers. We'll talk about that in a minute. But more commonly, the agents we use to treat seizures, if they are acutely withdrawn, can predispose to seizure activity. The same is true for benzodiazepine withdrawal and alcohol withdrawal. So particularly alcohol withdrawal, we worry about managing seizures, and we'll use the very drugs we use for treating seizures also as part of alcohol withdrawal protocols that might be the benzodiazepines, or that might be one of the other antiepileptic drugs, or both. We'll talk more about that when we get to substance abuse as the curriculum at another point. We also worry about any of the stimulants. Cocaine, certainly, any drugs of abuse we're going to worry about with a new onset seizure. Amphetamines, even decongestants like pseudoephedrine or phenylpropanolamine that are contained in cough and cold preparations could be a problem. And then the rest of the table lists some varying agents that have been associated with seizure activity as well. To my mind, a little less common, but not unheard of to see that. So when a person comes in with a new onset seizure, one of the very first things we look at is getting immediately a tox screen and to get a good history to determine if any drugs that could lower seizure threshold have been initiated, or if a drug that is suppressing seizure activity is quickly withdrawn. When we think about a nerve conduction and how that relates to seizure activity, if we can augment or slow nerve conduction by affecting sodium or affecting calcium or one of the other electrolytes that are electrically charged, or affect gamma aminobutyric acid, which is the body's natural electroconduction suppression, a way to sort of slow nerve conduction by augmenting gamma aminobutyric acid or GABA. Any of these are potential interventions for antiepileptic drugs. And they really fall into three categories. Ones that affect sodium transfer across the fiber, agents that affect calcium, and agents that affect GABA. First, let's look at sodium. When we look at sodium across the nerve, a second approach is to look at the gamma aminobutyric acid as the body's natural means to slow down nerve conduction in the chloride channel. And so by augmenting GABA or gamma aminobutyric acid, we're going to actually slow down the nerve conduction itself. We see this as the primary activity of the benzodiazepines. We also see it for the older barbiturate agents. We see it for gabapentin, and we see it for felbamate and a few other agents as well. So the GABAminergic agents, GABA, gamma aminobutyric acid, minergic meaning mimicking GABA agents, are also used for slow nerve conduction. The last group of drugs are those that affect calcium channels, and these include zonisamide, ethosuximide, and valproate. And these agents in particular, the first two, are first-line agents. Valproate and ethosuximide are first-line agents for the generalized non-motor seizures, the old term absence seizures. And so it's believed that the calcium channel in that seizure type may be more important. And so these agents really have their role there. But because valproate also works at sodium channels, as we alluded to earlier, it has a broader spectrum of use in seizure control. So as we look at our antiepileptic meds, let's first look through this table relatively quickly to get a gist of what we're looking at with these agents, and then talk about some of the most of these agents in more specific terms in the rest of this block. This is a table, the first half of a table, that looks at different seizure types across the top and different agents down the side, and looks at whether these agents are first, second, third adjunctive therapy or used only in rare circumstances when there's no alternative. So we sometimes would consider, for example, adjunctive therapy as add-on therapy, or therapy that would be considered in refractory cases to use as well. And so, for example, for focal seizures, the first-line agents on this page include carbamazepine, gabapentin, lacosamide, lamotrigine, and Keppra, the last one on the list as well. And for focal seizures, you may pick any of those, but you may find that there's one or two of them that are going to be picked before others based on side effect profile or based on some other factor associated with the agent and or customized to that patient. And so while a first-line agent, you could choose any of them for managing those seizure types, we pick the agent in part based on the side effect profile and other factors for the patient that make sense. For generalized motor seizures, generalized tonic-clonic seizures, we'll see, again, carbamazepine and lamotrigine and Keppra at the bottom on this table are the major agents used. The last three seizure types are more limited in scope, with the exception of generalized non-motor. These are often, at the older term, absence seizures in childhood, and ethosuximide really stands out in this group as the agent of choice. For status epilepticus, and you're going to only see that likely in the emergency department, the only agent on this slide that you'll see are the benzodiazepines like diazepam, which is longer acting, and more commonly we're going to use one of the other benzodiazepines, usually a shorter acting benzodiazepine like Ativan or lorazepam. We'll talk about that in a bit. Maybe midazolam, very short acting benzo. So the second half of this table lists agents as well. And for first line, for focal agents, the only really first line agents here are oxcarbazepine, which is like carbamazepine, or zonisamide. And for generalized motor seizures, again, oxcarbazepine listed, but also topiramate, valproate, valproic acid also is first line down the list. For absence seizures, really the only agent that sort of jumps out here is valproic acid or Depakote. And finally, for status epilepticus, lorazepam or benzos are your first choice. And then sometimes after the benzo use, we'll see phenytoin. Phenytoin is a very interesting agent that used to be considered first line for both focal and for generalized motor seizures, and as well as status epilepticus. The reason why it's really become second line is because it's really a hard drug to manage. And while we'll talk about phenytoin a fair amount, because there are a lot of pharmacokinetic issues involved in its use, and it's complicated, the reason it really has fallen behind in use is because of its complexity in use. Similarly, an older agent that used to be first line for most seizure types is phenobarbital. But phenobarbital causes a lot of sedation for patients, a lot of mental dulling, and as such is really not a good first line agent because of the side effect profile. So let's look at some of the more commonly used agents, or some of the agents which at least have one consideration for first line therapy. So the first agent we'll talk about is phenytoin or Dilantin, an older agent that is really only first line for status epilepticus. It used to be a first line agent for focal and generalized motor seizures as well, but because of its pharmacokinetic profile, very difficult drug to manage. People can get toxic on it pretty easily. It really has rendered itself a second line agent for those indications. And it actually makes generalized non-motor seizures like absence seizures worse. Occasionally also used for neuropathic pain. So let's look at some of the factors that affect kinetics of phenytoin, which make this a really complicated drug to use. There are different oral formulations of phenytoin. There is a suspension, there is a tablet, there are capsules. The capsules are longer acting, so they're intended for many patients at once or twice a day dosing. But the capsules don't actually have the same amount of phenytoin in it that the tablets do. That the 100 milligram phenytoin capsule only has really 92 milligrams of true phenytoin in it, and the rest is the salt form, which makes dosing a little more complicated. Probably most importantly, phenytoin displays different elimination pattern depending on the concentration in the body. That it displays what's known as first order elimination or concentration dependent elimination at low to moderate doses. But once the metabolic process for phenytoin gets saturated, it then is a non-concentration dependent elimination, meaning that the body can only then, at that point, when there's a lot on board, for example, with a phenytoin dose increase or an overdose, a patient then doesn't metabolize it any faster than a certain rate. And so the amount that goes down each hour is the same, as opposed to the actual milligrams that go down in the body or get eliminated is constant until you reach the threshold where that metabolic process is no longer saturated. So that means that in phenytoin overdose situations, there's really no such thing as half-life until you get to the point where the body no longer has a saturated elimination process. That makes phenytoin complicated, dosing complicated. It's also protein bound to albumin, and so in patients with low albumin levels or with competing other drugs that bind to albumin or who have uremia or renal failure, those folks have elevated percentage of the phenytoin is freed across membranes. That makes phenytoin more complicated to dose as well. And then phenytoin has many drug interactions. It's an enzyme-inducing agent, and it interacts with many other drugs, and we'll look at that drug interaction pattern for phenytoin a little later on in this presentation. So as such, phenytoin is complicated. The dilatant capsules we alluded to, the bioavailability is a little different. Tube feedings can affect the bioavailability as well. It's highly protein bound. Its volume of distribution can vary based on the fluid of the patient, but its volume of distribution, known as about 0.8 liters per kilogram, affects where dilantin goes to. And some of it, of course, is going to be distributed in the central nervous system because it is an agent that works via nerve conduction. But all of these factors make the kinetics of and the management of dosing of phenytoin more complicated. So things to think about that we usually think of the half-life of phenytoin as about 22 to 24 hours, meaning that at steady state when you're going to get a level, you're going to get a level 5 days out. But if you saturate the metabolic process, there's no such thing as half-life. And so you have to worry at high doses whether or not the drug could accumulate. There are standard levels we'll look at monitoring, either the total or the free level, and there are phenytoin correction calculators for patients with a low albumin or a high bilirubin or BUN, and I encourage you to go to a website. One of them is called, well, any medical calculator can do that, but globalrph.com, I think, is one that many pharmacists will use that have a number of calculators on them on that website, and phenytoin calculator correction calculator is there as well. In addition to the kinetic issues with phenytoin, there are lots of adverse effects. If you gave this drug IV push, it would be fatal, so it has to be given slowly because of cardiac arrhythmia risk. It also is very irritating, and so we more likely in IV administration use fosphenytoin, which we'll talk about in a minute, which is a phenytoin derivative, which is a little less irritating and can be given a little more quickly IV in status epilepticus. There are other side effects you'll see. Patients might have nystagmus, behavioral changes with its use, and they almost look like they're drunk. You'll also, and that's usually if it's higher levels. You also can see at very high levels an increased risk for seizures. That's unusual for anticonvulsants, but not unusual for high-dose phenytoin. And so we want to keep an eye out for that, as well as GI upset. Other things that are sort of somewhat unique, but not totally unique to phenytoin, is that it's associated with gingival hyperplasia. And you'll see gums get quite enlarged, so good dental hygiene is critical with phenytoin, as well as perhaps folate supplementation, but the folate itself, when you supplement it, may affect phenytoin levels. And finally, some of the anti-epileptic drugs, particularly phenytoin, and we'll talk about later phenobarb, maybe to some extent some of the other enzyme-inducing drugs like carbamazepine, could be associated with vitamin D metabolism, and therefore the risk for osteomalacia. And so many patients on long-term phenytoin would benefit from vitamin D and calcium supplementation. So all of these make phenytoin really a second-line drug because it's complicated to dose and some of the adverse effect profile are complicated as well. The dosing of phenytoin is listed here, but the typical dose in status epilepticus, which most clinicians, that's when you're going to really initiate phenytoin, is something in the range of 18 milligram per kilogram as a slow load. If they have a very low albumin level or they're in renal failure, we often would start at half of that dose. And if they already have phenytoin on board, but they're a little subtherapeutic, then you look at the difference and you might give them only 4 or 5 milligram per kilogram to make up the difference. You wouldn't give them the full load again if they already had phenytoin on board. We alluded briefly to fosphenytoin. Fosphenytoin is a derivative of phenytoin that is less irritating to the vein on IV administration, and you can give it a little more quickly. There is also the availability of giving it at the faster rate with less cardiac risk associated with it. And so when we give IV phenytoin, usually we prefer to give the fosphenytoin formulation, which is dosed a little more quickly. And you just have to be careful to dose it at the appropriate amount and at the appropriate rate. Another common anti-epileptic drug is carbamazepine or Tegretol. This has been around for 3 or 4 decades now. It works also with sodium channels. It's really first line for focal and generalized motor seizures. It's also used as a second-line agent in neuropathic pain and as a second-line agent in some patients as a mood stabilizer with bipolar states. And it's absorbed pretty well orally. It's not available IV. It's metabolized to an active metabolite that has some anticonvulsant activity, but that metabolite also makes folks almost look like they could be drunk, ataxia, dizziness, changes in mental status. And so we worry about carbamazepine side effects in dulling patients a bit, and that can happen. Carbamazepine is an interesting drug that is an inducer, that it induces enzyme function for other drugs, so it interacts with a lot of other drugs. And it's one of the few drugs that actually has a concept known as autoinduction. When we start somebody on carbamazepine, it actually induces its own metabolism. And so what we find is that you may start somebody on carbamazepine, and after a few weeks, the levels may go down and they need a further dose increase. The other issue with carbamazepine is that it causes a lot of upset stomach, gastric distress when we start it. And so we typically have to start at a low dose. So we might start at somebody at 100 or 200 milligrams twice a day of carbamazepine and work up our way on dosing over the next couple of weeks or so until we get to that full therapeutic dose. Even then, we get to them at a dose within a couple of weeks. We check a level at the appropriate time. And then we may need to get a second level 4 to 6 weeks later because of this autoinduction process that's happening. Finally, one of the big adverse effects that we historically really worried about with Tegretol and still have concern about, but not to the degree when the drug first came out, is bone marrow suppression. When this drug first became available to the market, we were quite worried about the risk of suppressing bone marrow and seeing a drop, particularly in neutrophil counts. But that is, in most patients, a modest effect, not a significant one. We still look at white blood cell count monitoring and full CBC monitoring for patients on Tegretol. You would probably want to be considering another agent if a patient were immunosuppressed in any way. So patients on chemotherapy, patient has a chronic infectious process going on, they have HIV, they have tuberculosis. Maybe carbamazepine is not a first-line agent in those cases, but usually that's not clinically all that critical. We just monitor it, and if it becomes a problem, then maybe we do consider an alternate agent. One other side effect you'll see with carbamazepine that happens surprisingly frequently is changes in sodium levels and fluid retention. We see a drop in sodium or syndrome of inappropriate ADH secretion with fluid retention, and so you see a hyponatremia, and usually that can be managed for folks on Tegretol by just limiting free fluid intake, limiting patients drinking a lot of excessive water. But if that doesn't seem to work, maybe Tegretol has to be discontinued and another agent considered. Trileptal or octacapazepine is an analog to Tegretol, and in my mind, I think of it as almost like Tegretol. It's a slightly different compound. It doesn't have the same metabolite as Tegretol, so maybe there's a little less of that central nervous system dizziness seen. But there isn't a drug level to monitor, where with Tegretol we have a standard level that's considered the therapeutic range that we could monitor with Tegretol. So this is the first of the anti-epileptic drugs that we've talked about so far that we don't get a blood level for. We get blood levels routinely in monitoring for phenytoin and for carbamazepine. We don't routinely do that for Trileptal, at least in the practice that I've seen in general medicine. Another anti-epileptic drug with widespread use because it's used for things other than standard generalized motor seizures is valproic acid or valproate. And this is a very interesting drug. It affects both sodium channels and, to some degree, calcium channels. And it may even have some beneficial effect with gamma-aminobutyric acid. And so of all of the anti-epileptic drugs, valproate has the broadest spectrum of activity. So it's indicated as a first-line therapy for generalized motor seizures. It's also interestingly, a first-line therapy for generalized non-motor seizures or the absence seizures of childhood. It's also indicated as an agent for infantile spasms, which are very difficult to manage and are hard to manage, and a second-line agent for focal seizures and status epilepticus. It's also used in mental health pretty commonly or fairly commonly in patients with rapid cycling and bipolar conditions. So we see it used not infrequently in mental health as well. I've also seen it used as an agent in some protocols for alcohol withdrawal protocols, and so it's sometimes used in some settings for that as well. Its bioavailability orally is excellent. The divalproex formulation basically is a longer-acting formulation because it takes two of the molecules of valproic acid, links them together, and so those are slowly cleaved in the gut over a few hours and allows the drug to be better tolerated for GI effects and dosed a little less frequently. There are multiple forms of this, and you just want to make sure when you're giving Depakote or divalproex that you're using the formulation that's intended either for once a day or for more than once a day. The formulations are a little different. You just want to make sure you get the right one. It's metabolized pretty extensively. There are a fair number of interactions with valproate, so we'll talk more about those interactions in a little bit. But the half-life is relatively short, and so you can reach steady state and get levels for valproate usually within 4 days or so. The therapeutic range, the levels we'll get typically for seizure control is usually somewhere between 50 and 100 milligrams per liter. When we use it for bipolar, we usually have to hit the 100 or so range to see efficacy. Sometimes we even need to go up to 125 milligrams per liter in our treatment for bipolar. The adverse effect profile, Depakote or valproate, fairly well tolerated in most patients, but the side effect profile is notable here, and let's go through some of those. You can see some stomach upset, not as bad as we saw with carbamazepine, but you'll see it, particularly with the original valproic acid form, a little less so with divalproex. What you do see, though, is weight gain. Patients on Depakote will often gain weight and gain a lot of it. And that is one of the limitations that a lot of clinicians and patients have with its use, is that patients always feel hungry. It seems to reset their hunger sensation, their satiety level, and so patients often gain a lot of weight, sometimes 10, 20 kilograms. That's 30 pounds or more for many patients. They could have alopecia or hair loss. There is always the risk for pancreatitis and hepatitis, and that's a concern particularly in young children or patients who have a history of pancreatitis or a history of liver dysfunction. Most of the data for hepatotoxicity with Depakote or valproate came early on when the drug was first on the market or first studied in the late 70s, early 1980s, and most of that data was with young developmentally disabled or mentally retarded children, but we see it in other patients as well, so we're always aware of it. And the pancreatitis also can be concerning for us, and so when we see someone who presents with anything that looks like pancreatitis, and there'll be more of that in the GI block, but we would look at they on Depakote and would we get them off of it. Finally, thrombocytopenia is a dose response type of phenomenon with this agent, and you'll find that typically with high dose, when we really push the dose of valproic acid, you find that thrombocytopenia risk is greater. So you're looking at platelets for folks on this agent, and will back off platelets, back off the dose, or stop the agent if the thrombocytopenia becomes significant. An advantage of valproate is that there is an IV formulation. So for folks who are NPO, there is a way to get valproate in them as well. There's also multiple formulations. There's a liquid formulation. There's also a sprinkle formulation, a capsule that can be opened up and mixed with food. So it's a pretty widely used drug as either first or second line agent in seizures, and also a first or second line agent in mental health. Another agent that you'll see used, probably more so in mental health actually than we see used in, at least that I see used, for seizure control, but is a first-line agent for some seizure types, is lamotrigine as well. And so for focal seizures or generalized motor seizures, Lamictal or lamotrigine is a reasonable agent to consider. It's also used for generalized non-motor seizures and can be used in bipolar states. And in fact, in many settings in mental health, this is one of the first-line agents used for bipolar. And so this is an agent that comes back we talk about more in the mental health block. It is moderately available, bioavailable. It's got some absorption issues with it that might vary from patient to patient, but it's not unreasonable. It is metabolized. The issue we have a concern with lamotrigine, though, is that the lamotrigine is highly affected by concurrent drugs that are administered. And so depending on whether you have an enzyme-inducing or enzyme-inhibiting drug on board at the same time, you worry about the half-life accumulating. And one of the concerns is that high levels of lamotrigine increase the risk for the life-threatening Stevens-Johnson syndrome. And so we are particularly concerned about that risk in patients who have high dose or have high dose concurrently with valproic acid or Depakote. And so usually we try to avoid entirely Depakote and lamotrigine together. When it's appropriate to use them together, and that's sometimes used based on seizure type or based on control and bipolar, then we're careful not to use very much lamotrigine and careful about our dosing for that. Other side effects are dizziness and ataxia, drunkenness, somnolence looking kind of pattern, maybe a headache. And rash is pretty common. You always, though, are concerned whenever you see a rash that it's not truly Stevens-Johnson syndrome, which presents often, but not always, with perioral blisters or necrotic tissue, and that's considered a very serious scenario. So anytime you get any kind of rash, particularly one with blistering or with necrotic features associated with it, that is always a concern for Stevens-Johnson syndrome, and you want to make a careful evaluation of that, probably stopping the Lamictal and managing that patient appropriately. Levetiracetam, or Keppra, is also a pretty commonly used agent, at least in acute care. I'm seeing this agent as more commonly used for generalized motor seizures in situations with a sort of new onset seizure activity. And its advantage is that it is available both orally, and there is we see that it's IV. There's an IV formulation now available as well. And so it's a first-line agent for focal or generalized motor seizures. It can be used for generalized non-motor seizures and even status epilepticus in refractory cases. It's well absorbed orally. It's renally eliminated. The side effects profile is listed here. It's pretty well tolerated. The concern with its use, primarily, I think, in most clinicians is that it's an agent we might consider avoiding in patients who have a mental health history. If they have a problem with mood, hostile behavior, aggressive or assaultive behavior, or concurrent depression, Keppra is an agent that sometimes can make that worse. And so, as such, that's really, in many clinicians' practice, a reason maybe to consider avoiding it. There's also some question or concern about whether there's some immunosuppression associated with it. To my knowledge, that was seen in early data, and I've not seen clinicians really as worried about that as perhaps originally we were when the drug first became available. So at least in acute care, I'm seeing this agent being used more commonly as an add-on to standard therapy when seizures are particularly problematic in acute care. Interesting agent, gabapentin or Neurontin. This is an agent that works primarily at affecting GABA-promoting release of gamma-aminobutyric acid. It is considered a first-line agent for focal seizures, although I'll tell you honestly, I don't see its use in seizures very often. Most often, while it is used as even a second-line agent in generalized motor seizures, again, not commonly, particularly not commonly monotherapy for seizure activity. Where gabapentin is most commonly used is for neuropathic pain. And you'll see it pretty commonly used in that indication. In fact, many clinicians use this as a first-line agent for neuropathic pain. The advantage is that it's generic, it's pretty well tolerated in most patients. The downsides to it is that about as many patients who are going to have benefits for neuropathic pain with this agent, there are probably going to be as many patients who are going to have significant dizziness, ataxia, somnolence, or not be able to tolerate it because they feel clouded or confused or something. We also occasionally see weight gain with its use, and there is a lingering concern with gabapentin that there may be some habituation with it. And so many clinicians begin to think, hey, this is a drug that eventually is probably going to become a scheduled drug like pregabalin or Lyrica is. We'll talk about that in a minute because it's very similar to Lyrica. And so while currently, as of 2018, late 2018, this is not a scheduled drug by the Drug Enforcement Agency, there are even some hospital and healthcare settings that are treating it as though it is one. And many clinicians who work in substance abuse are looking at limiting using this agent for neuropathic pain in a patient with a history of substance abuse. So you'll probably hear more about that over time. Pregabalin or Lyrica, also similar to gabapentin, is really primarily used for neuropathic pain or fibromyalgia. It can be used in refractory cases or as add-on therapy in focal seizures, but again, I don't see that used very often for that purpose. Typically, neuropathic pain and fibromyalgia are the reasons we use either gabapentin, which is generic, or this agent, pregabalin. And in many healthcare settings and in insurance sources, they may actually not have Lyrica on formulary or not as a first-line agent, and that you'd have to have failed gabapentin before you have access to Lyrica. Lyrica is a scheduled drug, and so that's a potential concern with its use. It's also associated with some of the same types of things we see with gabapentin. There's also been some question in a few patients of memory impairment and or psychotic reactions, and even the risk for allergic reactions like angioedema, although rarely. Another agent is topiramate or Topamax. It is considered a first-line agent for focal seizures and generalized motor seizures, and it has an indication in refractory cases for generalized non-motor seizures, pretty well absorbed orally. The big adverse effect, and why clinicians don't reach for this as a first-line agent usually, is that it has a surprisingly high rate of kidney stones. And so in really 15 out of 1,000 patients would see kidney stones, or 1 to 2 patients out of 100 would have kidney stones. That's really concerning as a clinician, that's considered pretty high rates because kidney stones are pretty significant. So you'd want to make sure that a patient doesn't have a history of kidney stones, but also that they adequate fluid intake to prevent them. Most clinicians look at just avoiding this agent and going to other ones first, and then limiting it to patients who would perhaps benefit from it where other agents haven't worked. There's also some data for other conditions, off-label use for topiramate, migraine headache use, or other things as well that you'll occasionally see used. But again, not all that commonly used agent, but still considered officially first line for some indications. Ethosuximide is a first-line agent for absence seizures, the generalized non-motor seizures. Either this agent or valproate Depakote are considered the first-line agents. And I think in most settings with new onset absence seizures diagnosed in children, we classically would expect that this is an agent that might be the agent that's often picked first. Rarely associated with other side effects, including Stevens-Johnson syndrome or aplastic anemia, but I think those are quite rare in practice. Zonisamide, another first-line agent for focal seizures, otherwise add-on therapy or refractory treatment for other seizure types. It can cause, like most of the other anti-epileptic drugs, people to feel like they're drunk, ataxic, or memory impairment, speech impairment, and that can be sometimes problematic, but we'll see that it's reasonable considered add-on therapy in a number of patients. Lacosamide, or Vimpat, is a Schedule V drug by the DEA. It may be considered a first-line agent for focal seizures and for refractory treatment in status epilepticus. A concern for its use is that it's associated with some cardiac changes, AV block, and it's also a scheduled drug with a risk for substance abuse. So in practice, I really see Vimpat is only an agent used when recommended by the neurology team in a patient who doesn't respond to other therapies. Most clinicians do not consider this a first-line therapy. Let's talk about some of the other agents that are either less commonly used or have their niche but aren't really first-line agents for most of the seizure types. One of these is phenobarbital. Phenobarb has been around for a long time and used to be a first-line therapy for most seizure types, particularly generalized motor and generalized non-motor seizures, focal seizures, and status epilepticus. And we still use phenobarb. In the setting I practice in, phenobarb is most often used for alcohol withdrawal protocols as part of an alcohol withdrawal protocol, and we see that used, at least in our setting and a number of settings across the country, as a pretty standard approach to therapy. Its use as an anti-epileptic drug still continues. It's usually limited to patients who may have tolerated and been on phenobarb for years and it's worked for them. Most neurologists would not consider starting a patient on phenobarb, particularly a younger patient, because it's so sedating, causes mental dullness. In children, it affects learning capacity, and so not a first-line agent. But the barbiturates themselves, IV, can be used also in patients who present with acute seizures and status epilepticus, and either phenobarb or pentobarbital, a barbiturate or alternative to phenobarb, might be part of a protocol when someone has not responded to benzodiazepines and or the addition of phenytoin. And so this is often used as a next-line add-on agent in that circumstance. But it's a long half-life drug, causes a lot of mental dulling, and outside of these limited roles, you probably won't see it used all that often anymore. Another older agent that is really not used much anymore is primidone. And primidone is actually metabolized to phenobarbital. It is a second-line therapy for focal and generalized motor and non-motor seizures. But again, because it is associated with a lot of mental dulling, we don't see this agent used that much anymore. Vigabatrin is used as an irreversible agent for GABA, affecting GABA, but really its use is pretty much for refractory cases. In practice, I don't see this widely available or widely used. Side effect profile is troublesome, particularly for folks who may have some sort of mental health history in their background as well. And most often it's considered investigational and/or as a last resort drug, not a first-line agent. Another agent, felbamate, became available on the market a couple of decades ago, but is really limited because of concern for aplastic anemia for only refractory focal seizures and refractory generalized seizures as well. Particularly its effect on bone marrow suppression has rendered this drug really a drug of late or last resort. Clonazepam, interesting drug. It's a benzodiazepine. Any of the benzos are very effective acutely for managing status epilepticus and seizure activity. The clonazepam is used for other seizure types, but it's considered second line because it is really problematic for patients long term, that it doesn't seem to work long term. It's refractory. It's used for refractory focal seizures or generalized motor seizures are there. Most often where I see it used for is for generalized non-motor seizures in patients for whom it's indicated. It's a benzo. The problem with benzos is that tolerance typically develops within 3 to 6 months for a good number of patients, and so as such usually is not rendered a great long-term therapy. Here's an agent, perampanel, which I have no experience with, and it is really limited to refractory cases for focal seizures. It's a Schedule III drug with a serious black box warning about behavioral reactions in patients, including homicidal ideation. And so any agent that has this kind of a black box warning in general is going to be quite limited in its use. I think clinicians are worried about their own liability in prescribing this agent if a patient has a behavioral change and then has homicidal type or hostile aggressive type of behavior. And so I've never seen this drug used. I think it's probably not likely going to be used very often. Here an agent is chemically appears to be similar to Tegretol or carbamazepine, Aptium, enhancing sodium channel activity. Its use is really for refractory focal seizures, and as such, I think as a clinician, you're less likely to see this agent used either, unless there's some new studies that come out that render it a more commonly used agent. Another agent that was brought to market in the last decade and removed from the market because it wasn't used is Potiga. So we don't need to really talk about this. But what you'll find is that there occasionally are new drugs that do come to market, and either because of their side effect profile or their lack of clear, great benefit, end up not staying on the market or falling away from common widespread use. Banzel, another agent that affects sodium channels, is indicated for either refractory or add-on therapy for focal and for generalized motor and non-motor seizures. An issue with its use is its effect on the QT interval and cardiac changes. And so, as such, I don't see this agent used very often when I see patients coming in acute care, but it may have a particular niche in patients for add-on therapy when other things have not worked. Gabatril, another agent that is used for refractory or add-on therapy in focal seizures, but has a potential risk for new onset seizure activity by itself. And so, I don't have any experience with this agent. Okay, let's look at some of the pharmacokinetic issues and these couple of busy slides that are here. What I've tried to do in some of these slides is to highlight for you those in red boxes that are commonly used for seizure management, and then in a blue box when it's an agent that's pretty commonly used, but the indication is not for seizures. And let me try to highlight what I think of as a pharmacist when I see these agents that are boxed or highlighted as what are the major pharmacokinetic issues. So for carbamazepine or Tegretol, this is a drug that has to be slowly administered over time because of GI upset. So we start at a low dose orally. It's only available orally, and we work up our dosing over a couple of weeks because of the GI tolerance. We have a standard level we'll monitor. 4 to 12 is the serum level. We'll get that with Tegretol or carbamazepine. And we may have to look at its active metabolite accumulating, causing CNS toxicity. Typically what you'll see is that you have to wait. Its half-life is fairly short, 12 hours or so. But keep in mind that it has auto-induction over time, and over time you'll have to get, in a few weeks, have to get another level to see if the levels have gone down by this auto-induction phenomenon. The next agent I've listed here in boxed is ethosuximide. I have little experience with ethosuximide because I don't work in a pediatric hospital. It's primarily indicated in pediatrics, but it's an agent of choice in pediatric patients with absence seizures. So you may see it used there. The alternative that's used in this type of seizure in the generalized non-motor seizure or absence seizure is valproate. Third agent that you will see used pretty frequently in practice is gabapentin. Not so much in seizure control, but in neuropathic pain. And this is renally cleared. And so when you think of gabapentin, you worry about full-blown doses of gabapentin in a patient with renal insufficiency where they accumulate it. So we usually will titrate the dose until their nerve pain is better, or they start to get dizzy, somnolent, or have trouble driving or something like that. Keep in mind that any of these agents that we give as anti-epileptic drugs can affect people's ability to safely drive, to safely work with machinery. And so you want to make that kind of an assessment when you're looking at a patient to make sure that they are safe to drive while they're under the influence of some of these agents. But gabapentin also dose adjusted in renal dysfunction. Lamotrigine, an agent you'll see more used in my mind in mental health, but you will see it used also in seizure controls as well. And lamotrigine is an agent we worry about some of the drug interactions we alluded to, particularly with valproic acid and the risk for Stevens-Johnson syndrome. So that's going to be a concern for us there. And we don't routinely, to my knowledge, get serum levels, although some labs may do them. But if they're send-outs, meaning the lab doesn't do them on site, then it delays the ability to get the response in a timely way for you to get that level in a meaningful way. The next agent, Keppra, is used more commonly in the acute care setting in the hospital. I see this used, probably it's used in practice as well in outpatient settings. Pretty well tolerated to what I see. Oxcarbazepine, while it has standard levels that are listed here, I don't see that as an agent that levels are routinely obtained. Phenobarb, older agent, you might see it used for alcohol withdrawal protocols, long-acting agent, but typically not likely going to be seen long-acting for most indications these days. Phenytoin, we talked about a lot of complicated issues with phenytoin, and so I encourage you to go back and look at what we talked about in those slides. But we do have standard levels we'll get for phenytoin, 10 to 20, or if we get a free phenytoin level that's not bound to albumin, our goal level there is 1 to 2, excuse me. Pregabalin or Lyrica for neuropathic pain, typically we don't get levels in that case. It's a controlled drug as well. And on this last slide, for a couple of kinetic issues, particularly valproate or valproic acid, that's the one I really want to zero in on this discussion, is widely used. We do get levels for that routinely. You want to make sure that the formulation you're using, the Depakote formulation particularly, is appropriate for the duration you're giving. There's really only one formulation of divalproex, which is really valproic acid. There's only one formulation of that tablet form that's indicated for once a day. So you want to be careful about which formulation you have and how frequently you're dosing it. other sort of footnotes for that set of slides there. As far as dosing ranges go for agents, I'm not going to focus on these slides, but they're listed again with the more frequently used agents here. You'll see for many agents we start with a lower dose and may or may not titrate upward on dosing based on either the control of the seizure or control of whatever condition we're treating or the tolerance and for adverse effects. And so you'll see things sort of vary. You'll also see with lamotrigine, the dosing varies depending on the concurrent drugs it's dosed with because of all the interactions with lamotrigine. Similarly, you'll see other sort of dosing ranges listed here. And here. We worry about a few other things in clinical practice as well. One is that sometimes seizures can be worsened by anti-epileptic drugs, particularly true for phenytoin, but you'll see the sort of listed here. Sometimes the other issue is that the drug itself may be beneficial for one seizure type, but make a different seizure type worse. And so you want to be sort of aware of that. And then you always want to worry about sudden withdrawal of anticonvulsants, and that's a risk for patients who are on long-term anticonvulsants who come off of them quickly. And so anticonvulsants, coming off of anticonvulsants, you want to taper them under the guidance of a neurology service, that you don't want to be doing that alone, and you want to be aware of that. Let's talk a bit about the management of status epilepticus, but we're really concerned about the causes of it and to try to get to the root cause if possible. Status epilepticus with continuous seizure activity. We see this with anticonvulsant withdrawal. We see it with cerebrovascular disease, alcohol withdrawal, and other sort of serious conditions where you have to, to the extent possible, address the underlying cause of the seizure activity in conjunction with managing the status epilepticus itself. Our treatment typically is management is airway, and first line is to give a benzodiazepine. Typically, lorazepam is the agent we'll see given first, and or you could use diazepam. You could use another benzo as well. Midazolam I've seen used as well. But that's really, you'll give them a lot of lorazepam, typically dose after dose after dose until you get control, and then maybe start them on IV phenytoin, or more commonly fosphenytoin, as we alluded to. If that doesn't get patient seizure control, then phenobarb may be layered on, and then looking at layering other modalities. And we alluded to a couple of agents. Keppra, for example, could be added to the mix. Now there are other choices. Often you have to call in anesthesia and or look at a phenobarb, pentobarb coma, and or continuous benzodiazepine drips for patients as well. Withdrawing anti-epileptic drugs, you're going to be really doing this carefully in patients who are good candidates. A patient who is a better candidate for withdrawal are patients who have not had seizures in a long time, haven't had head trauma, their EG is normal, they've been seizure-free, but you have to weigh the risk and the benefits, because the risk for new seizure activity, among other things, in most states across the country, that means you as a provider have to notify the motor vehicle department of the risk of this patient having a seizure while driving, and the patient may lose their driver's license. And so you want to weigh the risk and the benefit of that. Now, driving, another issue is that you want to make sure that a patient who has seizure history, has seizures in good control, but is on some of these anti-epileptic drugs. The drugs themselves can cause sedation and impair driving or impair ability to move, use machinery, or those kind of things. And so you want to be concerned about the safety risk for that. There are a number of different agents that have some recommended guidelines for withdrawal when it's done, but typically for a patient who's been an anticonvulsant or anti-epileptic drug for years, and for a seizure problem in particular, we look at making that withdrawal one agent at a time over months, and that's usually done under the guidance of the neurology service. The other issue we think of whenever we add or subtract any drug from a regimen is what interactions are happening and what is the withdrawal of that drug, for example, having on the levels of other drugs the patient is on, particularly other antiepileptics. And we talk about that in this next block when we talk about drug interactions. So with interactions, there are a great number of antiepileptic drugs that will interact with each other or with other drugs. Particularly, this is true, phenytoin probably has the most of interactions. Phenobarb do as well. And so those two agents, thankfully, are a bit in the background. We don't use them as first-line agents. But any of the antiepileptic drugs have a lot of interactions, including carbamazepine, lamotrigine, and then phenytoin is another agent that has a lot of interactions with protein binding as well. So there are a list of tables here for lots of drugs that have interactions. And I think at this juncture, it's not as important for me to go through all of these. What is important is to recognize there are many interactions, particularly among the antiepileptic drugs themselves, that'll affect the increase or decrease metabolism of them. And you always want to use some sort of an interaction checker when you're adding or subtracting any drugs for patients on these therapies. You want to look at if you have an automated medical record, electronic medical record, and you're adding or subtracting a drug, particularly adding a drug, there'll be an interaction checker. When you subtract a drug, there often isn't an interaction checker. What you still should do is when you subtract a known drug like these epileptic drugs, when you're taking it away, you should probably also run a drug interaction check because the opposite of what would happen when you add it is likely to occur. What you'll see for most of the mechanisms of the interactions are that they either increase or inhibit the metabolism of a second drug. And so you'll see the agents here, Tegretol or carbamazepine, for example, affects the metabolism of many drugs, including itself. It's an autoinducer. You'll see this as a common theme. Most of it is metabolism interactions. With this table, lamotrigine, lots of interactions here affecting metabolism. Most agents, it will increase the metabolism or lower the levels of another drug, but that is very different with valproic acid, where you're really concerned about an interaction there. But you'll see most of the effects are relating to either increase or decrease drug metabolism. True for this as well, phenytoin, lots of interactions there. More interactions listed here. And then interactions with other medicines, and this is not an exhaustive list, this is a partial list. But you'll see, for example, Tegretol affects the metabolism of many other drugs. You'll see phenobarb and primidone affecting other drugs as well. Lamotrigine affecting other drugs, including hormonal contraceptives. Phenytoin, many, many interactions with phenytoin and other drugs. Valproate as well. There's also a concern with contraceptive use and different antiepileptic drugs, some of which, many of the antiepileptic drugs could have decreased the effectiveness of hormonal contraception as well. And so this might be a discussion with the patient if you're giving them an estrogen-based or a progestin-based hormonal contraception. You want to evaluate whether the risk of decreased efficacy is noted, and that it could be very problematic. So you want to be aware of that. Important interaction to consider. Other things that we think about, clinical things as clinicians, we think about in older patients, think about pharmacokinetic differences or pharmacodynamic changes, more likely adverse effects in older patients, differences in clearance or interactions with other drugs, renal elimination as well for some of the drugs that are renally eliminated, particularly gabapentin, is a concern for many of us as clinicians. Pregnancy risk and benefit is important. You want to be aware that many of the drugs that are used for seizure control are themselves known teratogens, but that said, even though the older nomenclature category for many of the antiepileptic drugs are C or D drugs, which are known teratogens, we still find that the risk of uncontrolled seizure activity during pregnancy is probably greater than the teratogenic risk for the antiepileptic drug. And so usually for women of childbearing age, you want to make sure that they know that both the seizures themselves and the antiepileptic drug we're using pose risk to a fetus, and so they should evaluate their risk and desire for becoming pregnant carefully in light of both of those factors, and then consider whether or not contraception is appropriate and consistent with what that patient wants. Also, if the woman should become pregnant or could become pregnant, you want to be clear with both the neurology team and the OBGYN team about the risk benefit and a plan for managing pregnancy and seizure control. And so usually in pregnancy, clinicians usually try for all women of childbearing age to try to get them to monotherapy if that's possible during childbearing age, to make sure that, okay, if we're going to use an agent, let's see if we can control you on an agent that is going to both provide you the best seizure control and the least risk for a fetus. And so that's really a turf to both neurology and OBGYN. There are guidelines that are there. There's certain agents that are looked at avoiding here. Some of the specifics are listed here. Some of the other principles that are recommended by national standards are listed here as well. Other considerations, driving, as we alluded to, depending on the nature of what's going on in the state or region you're practicing in, you want to be aware of that. But that sometimes you're required to report to the Department of Transportation things that would require driving restrictions to be placed on patients. That's quite burdensome for a lot of patients, affecting their employment ability, affects lots of things. So you want to be very careful about that. And similarly, who are candidates for discontinuation of medication? Most often when I see that in practice, I would see that really under the purview of the neurologist, and looking at who are good risks for not having withdrawal seizures or new seizure activity once you take away the drug. Whenever you're removing a medication as well, you want to consider all of the interactions that are happening with the removal of that agent as well as you would if you're adding the agent on board. As far as monitoring, typically in practice, depending on the patient and their seizure activity, if they have relatively moderate seizures, our goal is always to get 0 seizures, and when seizures happen, to have them as minimal in duration and risk for injury as possible. When there are drugs for which there are blood levels for, we use the blood levels to guide our approach to therapy and dosing. That is particularly when the blood level is associated with a therapeutic benefit and a toxic side effect. And then adjust dosing carefully. Typically, though, again, with antiepileptic drugs, any dose adjustments are typically done in conjunction with the neuro team. Sexual dysfunction can happen with some of the agents that we talk about here, and so you want to have a discussion about whether that's an issue for the patient or not. The agents that are reportedly more problematic, carbamazepine, phenobarb, phenytoin, pregabalin, topiramate, and zonisamide. But they've been associated with other agents as well, and so that might be a discussion. Usually it's not a reason to stop therapy, but it is sometimes you may, if that's an issue for a patient, that may be an alternative to consider. Osteopenias and osteoporosis are seen with many of the antiepileptic drugs, particularly those that affect vitamin D metabolism. That's particularly true for phenobarb, for phenytoin, maybe carbamazepine. You may want to consider a vitamin D level in patients on long-term antiepileptic drugs and look at vitamin D supplementation as well. You want to consider the potential for suicidality with anti-epileptic drugs. This is less clear for what the risk is with the anti-epileptic drugs than it is with the some of the antidepressant drugs. But there might be some risks associated there. And so if you've got a patient who has some suicidal ideation, certainly we're going to avoid those couple of refractory agents we talked about with issues with patients with mental health issues. But some of the other agents may or may not be a risk as well. And the big issue is probably in practice to not necessarily avoid most of the anti-epileptic drugs in patients with a history of depression, but to carefully monitor their response to initiation of these therapies. Okay, there are a few drugs for which I think clinicians will see more commonly, and you probably want to be familiar with some of the more common doses associated with them. I hope this was helpful.